The high prevalence of fecal incontinence was poorly appreciated 20 years ago. We now recognise that it affects 2% of all adults and between 7 and 10% of people over 65. It has a major impact on patients' social and psychological well-being.
There's a very large number of people in the community with fecal incontinence, perhaps 2% or more of adults. There's no way that we're going to be able to treat all those patients with surgery, and nor would it be particularly appropriate to use invasive techniques such as that. At St Mark's Hospital we've been keen to develop non-invasive or minimally invasive treatments. The first of these, biofeedback, is a behavioural treatment that will help a significant proportion of patients. If that fails and patients have a degenerate or weak internal sphincter, we've devised the use of implantable biomaterials, that is PTP implants, to replace the internal sphincter.
The internal anal sphincter provides most of the resting anal pressure and is therefore the main muscle that prevents anal leakage. Disruption or degeneration of the internal anal sphincter can lead to passive fecal incontinence or soiling. This ultrasound image shows the central ultrasound probe. These concentric ring structures are the normal external and internal anal sphincter muscles. The internal anal sphincter is tonically active at rest, providing closure of the anal canal. The seal in the anal canal is enhanced by the 3 hemorrhoidal cushions, situated at the 3 o'clock, 7 o'clock and 11 o'clock positions. The internal sphincter can be disrupted at a single point, for example after surgical division, or have multiple disruptions, for example after anal dilatation. Alternatively, the sphincter can be anatomically intact but thin and atrophied. All these types of damage can result in a weak sphincter, which fails to maintain anal canal closure. The causes of internal sphincter damage and dysfunction are many. Damage resulting from surgery is common. Accidental trauma also can damage this delicate mechanism. Degenerative fibrosis or atrophy affects adults of any age.
Antidiarrheal medication should form the first line of treatment. Traditionally, operations have been used extensively to change sphincter function. Most operations on the sphincter have a high associated morbidity and a rather variable outcome. For this reason, we've pursued more conservative treatments, including the PTP implants. They're designed to replace a fragmented or disrupted internal sphincter and restore anal sphincter closure.
Joan is a 58-year-old retired civil servant. She's had passive fecal incontinence for about 20 years, following a hemorrhoidectomy in 1983.
Something to close up the anal canal a bit.
The symptoms have worsened recently, with motions up to 4 times a day and passive soiling at any time. Joan is otherwise healthy, and the problem is having a serious impact on her quality of life. Joan's ultrasound scan showed an intact external anal sphincter and an internal sphincter that was patchy, with a single area of disruption. Manometry showed that the resting and squeeze pressures were both low. These investigations support a diagnosis of passive fecal incontinence due to a disrupted internal anal sphincter. Joan tends to fluctuate between constipation and diarrhea, so she didn't get on well with loperamide. She's tried biofeedback, but there was no response. Having failed these treatments, she's a good candidate for PTP implantation. As part of the preparation for the procedure today, Joan has been taking lactulose 15 mils 3 times a day for 2 days. Now she's receiving prophylactic antibiotics, 160 mg gentamicin and 500 mg metronidazole intravenously but you could use a similar alternative. The entire procedure is carried out using strict aseptic technique. For implantation, the patient adopts the prone jackknife position. The area is cleaned and betadine solution is used to irrigate the anal canal. 1 hour beforehand, a topical local anaesthetic cream was applied. Now local anaesthetic is injected at the site of needle entry, 25 millimeters from the anal margin, and in a track leading up to the site of implantation. Each PTP implants kit consists of 3 PTP implants and a rigid 90mm 18-gauge needle. The administration device is reusable and is supplied separately. The implants contain solid medical-grade polydimethylsiloxane elastomer suspended in a hydrogel carrier. Because of the viscosity of the implant, there is a delay between squeezing the trigger and the start of the flow. Similarly, there is a delay between releasing the trigger and the flow stopping. The prepared and loaded needle is inserted 25 millimeters from the anal margin, medially and upwards across the external sphincter and longitudinal muscle, towards the interface of the internal sphincter and submucosa. It is positioned at the level of, or slightly above, the dentate line. In practice, the best way of localizing the needle and ensuring that it does not penetrate the anal mucosa is to insert a finger of the non-injecting hand.
Fantastic. All right.
The product should be administered slowly.
One more, that's
It's
it, all
important
done.
to wait 30 seconds after releasing the trigger before withdrawing the needle. This makes sure that the flow has completely stopped and also allows time for the material to settle, so that there is no risk of flow back along the needle track.
You've done it.
Experience suggests that the best results are obtained by positioning the 3 implants so that they augment the physiological anal cushions at the 3 o'clock, 7 o'clock and 11 o'clock positions. After the procedure, it's important to resist the temptation of using ultrasound to check the position of the implants. This can displace or compress the biomaterial at a critical time. Observation continues for 4 hours. Patients are then discharged with oral cephalexin, 500 milligrams 4 times daily, and metronidazole 400 milligrams 3 times daily for 7 days. Laxative should also be continued for 7 days. Over several weeks after implantation, the hydrogel is replaced by body fluids, and fibroblasts deposit collagen around the individual implants, holding them in place. 12 weeks after the procedure, it's safe to perform ultrasound to check the position of the implants. The procedure can be repeated, if needed, at this time. A recent publication from St Mark's Hospital reports on the results of a study using PTP implants in 6 patients after 15 to 19 months follow-up. 5 of the 6 patients had marked symptom improvement, associated with a significant improvement in incontinence scores.
With the refined technique, 5 out of 6 patients had marked improvement in their continence. Their continence score was improved and their quality of life was improved.
Quality of life, assessed by the short form 36 scores, also improved markedly, both in physical function and even more dramatically in social function.
There are 4 major improvements in the technique that have led to better results. We have to use strict aseptic technique. Patients are on antibiotics immediately prior to the injection and for several days afterwards. We give patients laxatives before the treatment and again for several days afterwards to make sure that they don't have any fecal impaction or strain after injections. And lastly, the technique of injection is important. We inject the biomaterial across the external sphincter, which therefore forms a seal so that the material can't leak out after the injection. Injection of the PTP implants leads to an increase in the resting pressure in the anal canal, which we think reflects an increase in the closure of the anal canal. For patients with marked passive fecal incontinence, the PTP implants are a major advance in treatment. These are patients who otherwise may have been faced with major surgery or a colostomy, and through this simple, minimally invasive technique we're able to avoid those kinds of major treatments.